You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hey everyone, welcome back to Just Medicine. If you recognize my voice, thanks for coming back. And if you're new here, my name is Annie, and I'm a medical student studying at UBC in my second year. I'm recording a series for this podcast on reproductive health, and this is the third episode on the series. The first episode was on access to contraception, the second one we covered cervical cancer, and today we'll be talking about rural pregnancy care. So it's pretty well known that pregnancy itself isn't exactly a walk in the park for most people, and navigating pregnancy for anybody can be challenging. But for those who live in rural locations, it also comes with additional specific challenges. In this episode, we'll be addressing some of the practical implications of rural pregnancy, like financial implications and more, as well as some of the more nuanced topics, like the cultural implications of traveling for healthcare and some of the less quantifiable things. But before we get into all of that, of course, I would like to introduce today's guest speaker. So Dr. Sheila Curran is a lovely family physician from Whitehorse, Yukon. She started her career working as a locum throughout rural BC before practicing for a few years in Prince George. After that, she moved to Dawson City in the northern Yukon for 7 wonderful years, providing full-service family medicine and ER coverage. Her practice in Dawson was supplemented with regular trips to Whitehorse, a quick 6-hour commute, to practice primary care obstetrics. After a year's sabbatical in Powell River, BC, she and her husband have recently moved to Whitehorse, where she works as a locum in primary care and obstetrics, provides sexualized assault response team on-call services, travels to Atlin, BC for regular clinics, and virtually supports rural BC providers through the real-time virtual support maternity and babies advice line. Outside of medicine, she also loves snow, animals, and riding her bikes.
Okay, so without further ado, let's welcome Sheila onto the podcast. Hi, Dr. Curran.
Thank you so much for having me.
Yeah, of course. So before we jump into the bulk of the episode, I'd love to hear some more about you. I read your bio to the listeners. It sounds really interesting. So yeah, I'd love to hear more about what your day-to-day work looks like now.
Yeah, well, at the moment, just since moving back to Whitehorse just about a year ago, I've only been doing locums, which has just been sort of a nice break in practice to be able to kind of pick and choose my work a little bit. I don't think I'll do that forever because work-wise, I do like the sort of longitudinal relationship that you have from having your own practice. It's rewarding, but it's also easier, honestly, to when you know the patients instead of going in cold all the time with people that you don't have a background with. So I won't do this forever, but at the moment, it is quite nice to just have a little bit of flexibility. And I've been trying to get to know my new community a little bit more by taking some time off and trying to work on projects on our new house and garden and things. So it's variable right now. My sort of anchor jobs that I always have, I'm part of the sexual assault response team here in Whitehorse. So doing forensic examinations and medical and psychological care to survivors of sexualized assault through our emergency room, as well as I have a job actually in BC, even though I'm physically located in the Yukon. There's a service called real-time virtual support that is geared at helping rural nurses and physicians who need help with their patients. And the goal of it, and maybe we'll get into it more as part of the podcast too, is to help be sort of a friendly, warm, supportive, understanding voice to peers who, and understanding maybe what people in a rural site are going through with the resources that they have, which when you call a busy hospital and you're trying to get a consultant and manage a sick patient, you don't always get that understanding. So I do some call with that. And in fact, I'm on call for that right now. So there's only like 20 minutes left in the shift, but small chance of an interruption for that. And at some point I'll have to like pause our chat and just sign over to my colleague. So those are sort of my anchor jobs that I have. And then I'm doing locums mostly for my colleagues who work in obstetrics here, and sort of like a permalocum with that team, and I will cover their family practice and their obstetric shifts when I'm working for their practices.
Amazing. Thank you for sharing. It sounds like you're doing really impactful work, and it's cool that you've done different things throughout your career and sort of, experienced a lot of variability with your career, it sounds like. Do you enjoy it? What's your plug for rural practice?
Yeah, great question. Well, I think I do really enjoy it, and I think it's a lot more interesting, and it's harder in some ways and it's easier in some ways. It's just different. Um, what's easier about it is you develop relationships with your patients and you develop relationships with providers in your community. So like I imagine working in Vancouver and I think like, who would I refer people to? I don't even know who any of these people are.
Hmm.
People would be scattered all over the city. I wouldn't know their lives. I wouldn't sort of be able to work in a team. I wouldn't be able to call someone up and say, hey, I really need your help with this person, and sort of creatively problem solve in a team. I
Hmm.
think it's end up being a lot more fragmented just through the forces of geography and of a big mass of people that you have in urban areas. So I like intimacy. I like intimacy in my friendships. I'm someone who has like a few good friends, not a million acquaintances.
Hmm. Hmm.
And I like it in my professional interactions. And so I think that's a really lovely thing that you can have in smaller areas is if you can know people well, they can know you well, and that those relationships, again, whether it's with your peers and your colleagues or your patients, you can use relationship as a therapeutic tool, as a resource, and that's
Hmm.
not easily counted, but it's a really valuable and rewarding part of my work, I think, really. So I guess if you like that kind of thing, there's my plug for you. And then lifestyle wise, like I like being in nature. I don't like being stuck in traffic. I like being on dirt. I don't like being on concrete. I like being in trees, not around skyscrapers. So if that's your jam, then it's pretty nice out here too.
Yeah, it definitely sounds intriguing to me. I like the emphasis on community because I think that would be rewarding both personally, but also in terms of practice, you're able to reach out to people more effectively, or you just, yeah, if you know who you're reaching out to, I feel like that would feel really good.
Yeah, I think so. Yeah.
Yeah. So is that what initially drew you to rural practice, or were you someone that always knew that was what you wanted to do, or did that kind of change throughout medical school? Yeah.
Yeah, that's a great question that I haven't thought of for a while. I think it was sort of probably a gradual evolution. Interestingly, both my husband, who's also a family doctor, and I grew up in different rural areas of Canada, and me in Alberta and him on the East Coast. And my understanding is one of the most predictive things about whether somebody ends up working in a rural area is whether they came from a rural area. And I don't think either
Hmm.
of us growing up ever felt a strong attachment to our particular communities. I sort of imagined always when I was a young person, like, I'm going to go off to a city somewhere. Um, but at the end of the day, it just kind of is where I feel more at home and more comfortable. So perhaps that even just goes back to those early years of how I grew up.
Mm.
Um, Honestly, I think how I started doing the work was that when I was in my training in med school and residency, it was kind of cool to do rural. Like it was, um, and that probably just reflects my peer group as much as anything, but there was this momentum towards it. It was kind of like a neat thing to do amongst my cohort. So perhaps that sort of piqued my interest. And then, quite frankly, as a new grad with debts, like the money was better. I could travel around. Housing was provided when I was living out of my car, driving around BC, being a rural locum. It was interesting. I was getting to do cool recreation, see the province, travel. So I was really enjoying that lifestyle. And then I probably just developed some um, skill and comfort working in rural areas through that early work and connections in some of those communities. And I guess it's just kind of continued on from there.
Thanks for sharing. Okay, so we've been talking a lot about rural healthcare. Now, assuming the listener doesn't have any experience with rural healthcare, and I myself don't know very much about rural healthcare either, how would you define or describe rural healthcare and how does it differ from urban healthcare?
Yeah, that's a great question. I guess like anything, it's probably on a spectrum.
Mm.
There are probably definitions for community size and things that make it
Yeah.
mark the cutoff. But the smaller your community, there's a few things that happen. You have less resources, right? There are many, many communities in BC where the health provider resource might be a lay person who's in a health support role. It might be that there's a nursing station and you have an RN. It might be that you have a visiting doctor to a place like that. It might be that you have a little bit more, maybe you have a clinic with some family doctors. Maybe you even have a hospital. Some smaller areas even have a few general specialists. So it's kind of on a spectrum to having more specialized types of providers, more different types of providers in the community. And the bigger the community, the less people have to travel to receive those more specialized types of care. So I think that's one of the key things about it, is there's a spectrum of how far away you are from services and how specialized those services are. I think we tend in healthcare, and certainly this is part of, I think, the unconscious curriculum in medical training anyway, that more specialized is better, right? Like, oh, this person's only been seeing a family doctor or a general internist or a gastroenterologist who doesn't specialize in their specific disease or whatever. Like, they should get to the most specialized person who knows all about this one thing. And when you need a diagnosis or to know exactly what the best treatment is, that can be helpful. But when you need an understanding of your context, when you need something that is adapted to an understanding of what your day-to-day life is, to what your values are, to what your financial situation is, that highly specialized medicine doesn't necessarily offer any benefits. And so there's advantages, I think, to those smaller communities where your providers are a little bit closer to your day-to-day, and know you a little bit better as well, and can give you that sort of personalized touch. So I guess that's the flip side of that spectrum of being close to resources. Like I was saying before, you have relationship and knowledge of context as a resource in opposition to that. There are still, of course, some things that you just need, right? Like sometimes you need surgery and you live in a place that doesn't have something like an operating room. Well, you're going to have to travel or forgo it, right? And those are decisions that people have to make all the time in rural areas sometimes, about whether or not to have healthcare, because the burdens that they have to incur to receive it might not work for them. I think that people with some decision making they wouldn't have otherwise.
Yeah, for sure. It sounds like an interesting balance of things because, and we'll get into this in a minute, but a bunch of the care centers for maternity care were moved away from rural locations some years ago. But the interesting thing is that, like you were saying, the rural healthcare, when it's there, and I'm meaning not having to travel for it somewhere else, but being able to access rural healthcare where you are in a local location, doesn't necessarily have worse outcomes or isn't necessarily less safe. And so that's kind of an interesting thing that's making it hard for me to understand why we would move away from rural healthcare in the first place. I guess resources is maybe a consideration, or staffing, but yeah, there's a lot to talk about there, and we'll get into it. But before we do, I'd love it if you could highlight not just differences with regards to rural versus urban care, but sort of starting to angle the conversation more towards maternity care and how that differs.
Yeah. Well, I think one thing is that in rural areas, care is much more likely to be delivered by a primary care provider, whether that's a physician or a midwife. An obstetrical care provider might be either a family doctor with an extra 6 months of training to provide advanced obstetrical care and C-sections, or a more generalist obstetrician. In terms of physician jobs, obstetricians in smaller, more regional centers often more play a consultant role. They're not doing primary care obstetrics and seeing low-risk patients for their prenatal care, or maybe seeing prenatal patients at all. They're acting strictly in a consultancy role. So that's a big difference in care, that the general care providers have probably a broader scope. As far as what patients experience, like you were alluding to, of course, they have to travel a lot more for their care. And that might mean that they're getting a lot of their prenatal care done by a nurse in a nursing station, and then occasionally checking in at a larger center with a care provider who may ultimately be part of the team that is there to deliver their baby if they travel to that center. So they may have multiple different people involved. They might be having somebody who's much more generalized and not focused on prenatal care, providing that prenatal care. And I think that has some interesting implications. We certainly, even in my career, and I graduated from residency in 2009, prenatal care has gotten way more complicated. There's more little details about who needs to be on aspirin for prevention of placentally mediated disorders, and who needs this, who needs that. And sometimes I wonder how big the impact of those little details are. I like details, so I do it all. But when you look at a population, you wonder. And it does mean that the more specialized and the more we focus on these little details of things, the harder it is for a generalist who's also, responding to car accidents and doing child checks and whatever else a nurse at a nursing station is doing, to be able to deliver prenatal care, right? But now we've also centralized everything, so that leaves a little bit of a conundrum for how best to link patients to the best care for them. And I think pregnancy is kind of a unique thing too, right? It's an area of care where we're quite proactive, where it's not an emergency, but it's always time sensitive, right? The pregnancy is marching on. There are things that need to happen at certain stages of a pregnancy, both to evaluate risks to the pregnancy and address and try to mitigate risks to the pregnancy. So it is, it's important to have good quality prenatal care and address these things in a timely way. And that is, I think, increasingly difficult as it becomes more complicated. And there are some patient factors to that too. People are older, maybe have more chronic health conditions themselves coming into a pregnancy, which also makes prenatal care a little bit more complicated. And now you have fewer and fewer providers who are comfortable with all those details of it. And I think that disproportionately impacts rural patients who are getting their care from some of the most generalized providers. And I don't say generalized as a negative, but the fact is that you can't know every single detail of something. So I think that's a big factor. I'll pause there if you have any questions, and then I don't know if you want to get the travel part of things is so huge in rural maternity care, so we can get into that or as a separate topic if you like, however you want to address it.
Yeah, for sure. I hadn't really considered the continually specializing aspect of prenatal care. Do you feel like rural healthcare, in terms of this, prenatal care getting more and more complex, do you think it's well supported at large by the healthcare system, or are there things that could be done better? It seems like it would be difficult to constantly readjust, having all these additional factors that aren't necessarily relevant to urban healthcare.
Yeah, I think so. I think that's exactly it, is that, the more generalized you are, the more you have to know a little bit about everything. And you don't have to know all of it, right? But you kind of have to know, oh, there's a thing about this if I encounter it, and so that you can find that out and get those resources and things. So I think it probably could be supported better. I think what tends to happen is there's judgment towards rural providers who are generalists. And honestly, I think this happens amongst more specialized and generalized providers within any geographical area, not just across rural and urban. It's maybe more about generalism versus specialization. But there tends to be a bias, and there tends to be, well, how could this person not have known this, or this? I didn't do this, or that in this patient's care. And I must say, I probably catch myself thinking that way sometimes. And I try to check that, because, when you're very specialized in a narrow area, you think, well, I know all of these things about this. Somebody else who's providing care to, say, a maternity patient should know it too. But they also have to know a whole bunch of things that you don't know as a specialist, right? They also have to know, in a rural area, they might not have to know how to take porcupine quills out of a dog, or they might have to know how to, interact with the coroner when somebody passes away. They might have to know how to, handle all of the administrative things that are happening at a hospital, because they're also the main admin person. They also might have to know all about different kinds of medicine for different stages and stages of life. They might also be acting as a pharmacist and a physiotherapist and
Yeah.
all these other things. And so, there's this enormous breadth of knowledge and skill, but it does mean it's a little bit more superficial in each of these areas, rather than really specialized. So, to answer the question, the downside to that dynamic, I think, sometimes is that when, as a generalist or a rural person, you're calling to get help, you often get it from these specialized people who don't necessarily have an appreciation of the breadth of knowledge that you have, and that there are skills and value inherent to that breadth of knowledge and skill that go along with that. And so it's really nice when there are supports available that recognize the inherent value there, as well as supporting with the enhanced specialized knowledge and skill and tools that somebody in a more specialized area has. So I think there's work to be done there for sure. Yeah.
That's really unfortunate that there's judgment there. I feel like rural practice would be really exciting and you definitely wouldn't get bored. It sounds like there's a lot of sort of nuanced things that you wouldn't necessarily have to know or deal with in a city center. But with that, I guess, comes a lot of responsibility and having to know a lot of these things that are added on to the other things that a general practitioner normally has to know. So I have a lot of respect for that, and that's amazing. But it's too bad that people don't always recognize that.
Yeah. And I shouldn't say that that's always the case, but it does, it is definitely a barrier, I think, to optimal support for sure.
Okay, so before we get into the impacts of the rural healthcare for pregnancy or maternity care moving away from rural areas, I know you're not primarily involved in policy, but I was wondering if you could just give us a little overview of what happened around 20 years ago in terms of moving these care centers away from rural locations and your perspective of why that happened.
Yeah. So I'm not totally sure. I mean, and like you say, I'm not involved in policy, nor was I practicing at that time. So I don't have huge perspective on it. My understanding is that it I think it probably followed some societal factors. There has definitely in, the last 50 plus years been a little bit of a move from rural to urban areas across the country. Right? There's been a drain towards urban areas. There's been change in workforce patterns, a little bit away from agricultural and resource extraction, a little bit more to other kinds of things that are more urbanized. So to some degree, there's been this population shift. There's been a little bit of a decline, not huge, but there has been a little bit of a decline in birth rates. And so I think there's been a desire to kind of consolidate services, right? If you have one little hospital with 8 births a year, and then down the road an hour away, you have another one with 8 births a year, and then down the road, another one with 8 births a year. What if you just put those all together? And to some degree, I think that makes some sense, right? And from a health human resources standpoint, we've had changes where we have a lot more women in medicine. Women have families of their own. Sometimes they get blamed for this sort of desire to have more like work-life balance, as if that's a bad thing. But the fact is men in medicine want that too. They're more involved in parenting their families too. And no longer does healthcare sort of rest on the backs of men who were willing to work super long hours because they traditionally had a wife at home taking care of everything else in their lives to make it
Yeah.
sustainable to be able to do that. So there are some cultural shifts in healthcare as well that probably contributed to that. And as things have changed in medicine, you just don't have people graduating who are comfortable necessarily, delivering babies somewhere where you don't have C-sections or blood or other resources, and also responding to ER calls and doing family medicine, maybe a little veterinary care on the side and in the emergency. We just don't have those comfort levels anymore. It's not how we're trained, and medicine's much more specialized. So there's so much other things to learn that people don't necessarily graduate feeling confident with that huge breadth of skill. And we're taught by specialists, right? We're taught in urban centers by specialists. And so you get this sense that you need to, be really strong at knowing how to do all these things. And then you're not, because nobody can be when you have an enormous breadth of practice. You're inherently uncomfortable all the time. And what you learn is that's normal. But if it's not normalized in your training, you're not going to feel very comfortable with that. So I think it's just had this sort of snowballing effect for cultural factors in society and health human resources, where we've just moved more and more away from that, and it's harder and harder to get back from that. I'm not a government bureaucrat, but I think there's also some cost-saving impetus there that, if we just scale it up and offer the same service to a whole bunch of people, we'll be, wasting fewer resources. And that's probably true if all you're doing is sort of counting, the dollars per birth, say, that it costs to keep these places open. And if you're thinking, we got to heat 3 different hospitals, where we could just heat one hospital and keep one nurse on instead of 3 different nurses on, there might be some cost savings there. Unfortunately, I think some of that cost saving gets pushed on to individual people in a way that is not proportionate or just or fair or considered. So
Yeah, so let's talk about the elephant in the room. So having to travel for healthcare as a rural patient obviously has financial implications. You have to pay for travel costs, food, accommodation. Specifically with regards to pregnancy, what I've been finding is that many people leave their rural communities at around 36 weeks gestational age to await labor in a referral community or center that is a lot further from home and in an unfamiliar place. So yeah, like you said, although there were their reasons, they had their reasons for shifting all of this to larger centers or to be more centralized. There's a lot of implications then and consequences for the individual. So I was wondering if you could just elaborate on how the having to travel for healthcare impacts individuals.
Yeah, I think it's huge. And even if, we touched a little bit on the costs that somebody has to incur to do that. So, even if government said, oh yeah, that's not fair, we're going to address these costs, we'll pay whatever it costs you to take. There are still some costs that aren't financial, right? And that can't be quantified and counted and paid back. So, and I think one of the hugest ones is support. So, people talk all the time about like, oh, I'm nesting, my baby's coming soon. I'm doing things to prepare and get ready and feel like I've got a warm, safe, cozy place for to bring my baby home. And if you're not home, you can't do that, right? Or
Yeah,
you
of course.
do it at a different time. The other thing is that people earn incomes, right? So if you have a job and your maternity leave, if you have a job, great. If you have maternity leave benefits on top of what you might get through EI, great. Or if you have enough hours to get EI benefits, great. Some people don't even have those things, though. And so, many people would continue to work until closer to when their baby comes, and sometimes have to stop their employment earlier than they would otherwise in order to relocate. So that takes them away from that income earning potential. And then partners or support people might also this is a very common conundrum that people face. It's like, do I bring my partner with me? So when I go live in some unfamiliar community where I don't have my usual support network, I'm not in my usual own cozy bed at this time, that just like feeling safe and cozy is so important. Do I bring my partner with me so I'm not all alone navigating this? Or does my partner stay back in our community where they have employment,
Yeah.
so that we can continue to pay our rent and buy our groceries and, maybe save up, because newsflash, having a baby is expensive, right? And,
Yeah.
there's diapers and baby stuff and whatever. It costs people money, and maybe, gee, they want a little extra financial buffer in case something happens. And they have this coming, and they have this newfound urge to feel a little bit more secure than maybe they ever did before. And then you add, if there are any older children into the mix, well, now you're faced with, like, do I leave my young children, who maybe are so young I've never left them behind before, back at home? And if so, do I have somebody who can take care of them? And what's that going to be like for them for that separation? Is that going to be a trauma for them? Is that going to be a trauma for me? Do I bring them with me and then I have to find childcare in an unfamiliar place? Who takes care of them when I have to go into labor and have my baby? Does my partner miss the birth and I labor without a close support person because my partner's staying back to take care of our older children? Do I, if you're lucky, maybe you have some grandparents or somebody who can come along, but many people don't. And even if you do, that's an added cost, right? Now you've got somebody else to put up in some kind of temporary housing situation. And maybe you're living together with your in-laws or your parents, and you get along with each other, but normally you would just be in your own individual homes during a time like this, and not having to navigate that closeness of family dynamics that sometimes does a little bit better separately. So it has all of these implications on just like how you organize all these players that are just your normal day-to-day life supports, let alone that you don't have your best friend and whoever else is normally in your life during that time. So I think it's really awful. And there's yes, it's helpful if you have money that will redress some of that, but money won't solve all of those problems at all, right? So.
Yeah, for sure. I'm so glad you mentioned these conundrums. I was going to ask you about that because it sort of seems like a bit of a lose-lose situation when you're deciding between, do I have social support or do I remain financially somewhat stable? So
Yes,
not
terrible
everyone,
situation.
yeah, it really is. And not everyone has a partner either. So then how do you navigate that if you're a patient who's pregnant and you don't have a partner? So then, well, what do those patients do if they're supposed to travel at around 36 weeks to live somewhere else and wait for labor? I don't know. How would you manage that? Because they can't stay to work at that point.
That's right. Yeah. I mean, sometimes people manage it by making the choice to stay in their community longer than they've been advised to for the sort of strictly obstetrical reasons. And people get their knickers in a knot about that, right? They feel like, oh, this person's, not taking good care of their pregnancy. They're taking on a risk. They're exposing the providers here to the trauma of having to, potentially deal with an unexpected birth in this area. But gee whiz, I'm not here to judge. Like, I don't know what I'd do in that situation, right?
Yeah, no kidding.
So it causes people to make choices that maybe they wouldn't if circumstances were different. And it's it is kind of a lose-lose. And there are, I think, huge mental health impacts of those choices that are so suboptimal for people. So I think one thing that governments could do is address more supports. It's never going to be the same as having your own network. It's never going to be the same as having your own people, right? That is familiarity, and that is family and friendship, and you can't just sort of drop somebody in and say, this is a birth support worker, as if it's going to be the same.
Yeah.
But gee, what if there was somebody who was an early childhood educator and also a birth support worker, and you knew that there was like a really good babysitting service available, and if you had to go into labor, somebody who'd already had a chance to meet your kids and be involved with your family would come over, and that might help, so
Yeah.
what if somebody was kind of checking in on you every day and seeing how you were doing and saying, hey, let's go out for a walk, or I'll show you this nice area of the city that you're visiting, things like that. I think some of those things would make a really big difference. In healthcare, they're not the kinds of things that tend to get counted, right? Like governments feel the need to be accountable to taxpayers. They should be accountable to taxpayers. But what I notice happens is that is interpreted as, well, what are we getting for our money? What services does this person provide, right? How many X's do we get for this many dollars? And the kinds of supports that I think are missing are things that aren't really countable supports, right? They're not, it's about relationship and connection and community and support. And those things don't really fit neatly into that matrix, as opposed to, well, this home care nurse does foot care and they do toileting and they give the person a bath, and these are the specific tasks that they do, task oriented instead of relationship oriented in a lot of healthcare. And I think to the detriment of what we're able to do to help people.
For sure. It would be nice if there was some way to support more continuity of care, because I feel like it would be difficult and really overwhelming having to switch to a whole new set of healthcare providers as well. For your going through your pregnancy. I can't imagine having to, it's like you lose your social supports. You also lose the people you're used to taking care of you throughout your pregnancy medically. So yeah, I don't know if there's any initiatives or methods that they have to try to make people more familiar with the people that will be taking care of them before they move or anything like that. It would be nice.
Yeah, I mean, I don't know what's happening in different parts of BC. Definitely, like a nice thing that's come out of the pandemic, as I'm sure you're aware, is that virtual care has become a much larger part of how we deliver care. And that is, I think, especially great for people living in rural areas. Now, there's still some work to be done as far as infrastructure. So, for example, in the pandemic, when I was living in Dawson City, there was all these, okay, this is how you can do video consults with your patients. But guess what? Our internet bandwidth actually wasn't good enough to support video connections with people. It was super fuzzy, drop all the time. You couldn't see very well. So, some of these things that from an urban area just seems like a no-brainer. Well, of course, we'll just hop on a Zoom call. You can do that with your patients. Well, actually, you need internet to do that, right?
Yeah.
And your internet might be delivered through a satellite because you actually live off grid and it's not very good. And if the satellites aren't lined up quite right, you don't have it that day, or there's a storm or whatever. So, but when it works, it can certainly help. And I think in maternity care, people do have often some of the care that they need, like ultrasounds, lab testing, things like that. They may have to travel a few times in the pregnancy as well. So like in Whitehorse, for example, we try to make sure when patients come in for their mid-pregnancy ultrasound that they always have an appointment at our office of family doctors who deliver babies to just even do a meet and greet, let them meet some of us. We try to make sure like all of our pictures and bios are up on the website so people kind of know who we are, just so they have that little bit of like a physical sense of like, this is where the office is, this is who the people are. I think it makes a big difference to just sort of visualize even one connection that you had with somebody. But it's not the same, that's for sure.
So I really would like to put the emphasis with this conversation on the non-measurable outcomes, like you mentioned. But just before we do that, it's interesting that the government isn't more inclined to shift things, because there are measurable outcomes that differ too for people who have to travel further for care during their pregnancy or while giving birth. So I was finding that there's multiple studies and they find increased rates of things like perinatal mortality, unplanned out of hospital deliveries, early induction of labor to maybe prevent longer stay financially in these
Yeah.
unfamiliar areas. So I don't want to put the emphasis of this conversation on just relaying statistics. I don't feel like I've done enough reading to really be confident in that. And I also don't think that that necessarily has to be the focus. I was just wondering from your perspective, why do you think all of these poor outcomes are occurring? Because those are measurable. And I know there's lots of factors that we've sort of touched on already, but what do you think are the main factors at play that are contributing to these poor outcomes?
Yeah. Well, I think there's probably factors related to, it's some of the things that we talked about, like how people's social situations are impacted by travel. And we know that your social well-being and your social supports impacts your perinatal outcomes. So there's probably some direct effect of it. I think it's also probably the case that, and I'm speaking as a provider based on my anecdotal experience rather than as a researcher in this area, which I'm not, that some of the underlying factors that influence people's health in rural areas are probably contributing too. So if you
Mm,
have less access to good prenatal care,
uh-huh.
more a higher chance that there are going to be problems and things that are going to be missed. We also know that people in rural areas in many ways tend to have lower socioeconomic status and lower health status generally anyway. So if you already have less less optimal health going into a pregnancy, your chance of having negative outcomes is also higher to begin with. And then you have less access to care in the pregnancy to try to address some of those risk factors. And then you have to travel. I think all
Oh,
of those
yeah.
kind of gradually compound. I think the other thing that's more recently coming to the forefront that we haven't touched on yet, but is really important, is many people living in rural areas are Indigenous, and they have known for a long time that they experience systemic racism in the health system. And only in the last few years is there a more public acknowledgement of that. And I think more conscious attempts to address that. And that, I'm sure, contributes to some of those negative outcomes as well, right?
Hmm.
It's the same kind of social effect as we've been talking about, but it compounds it and it disproportionately affects people of particularly Indigenous backgrounds. And it's another factor that I'm sure is contributing to some of those statistics.
Yeah, of course, it sounds like there's a lot of things that just sort of add up. I can't imagine having to try either from a practice or policy perspective to mitigate this because there's so many things at play. So I don't know where you would even start. And we'll get into that in a bit, but I really would love to talk more about what you were just mentioning. So I think that the travel risks we usually think of are like winter roads or maybe the financial implications, but we're starting to realize that travel risks also mean social and cultural implications.
Mhm.
So I was wondering if you could elaborate more on that.
Yeah, for sure. Well, I mean, I think if you're in your own community, you're known, right? Or if you are in your own cultural context, there are some things that people assume, right? We all do this, right? I think we all take better care of people who come from our same cultural background because we are making all these assumptions and having all these automatic thoughts and able to communicate things without realizing we're communicating things because we have this shared cultural background. So as soon as you're doing cross-cultural medicine, some things start to become lost, right? If you just don't know what to look for, you don't see it. And there's a bit of a cultural divide, just rural urban. And we know that there are big cultural divides that Indigenous people experience, and that unfortunately it is a group in Canada that, and it's certainly not the only one, but when we're talking rural healthcare, I think it's a really important group to consider, who have disproportionately experience discrimination and racism, latent biases and racism, and also horrible policies that have led to terrible changes in communities. And the legacy of some of those things, when you think about pregnancy and birth, when you think about the legacy as the residential school system, you had intentional fracturing of family systems. And when is a family system more important than around something like birth, right? You have wisdom and knowledge. How do you take care of a baby? How do you take care of yourself when you have a new baby? If you have not been around family and you're growing up, you've lost this huge amount of knowledge and skill. And if nobody else in your community has had that experience either, you don't know how to do it. How would you, right? And so there's just a loss of some of these basic kinds of family connection that Indigenous communities are doing, like beautiful and amazing things to bring back. But there is some really awful fracturing that has happened, that I think leads to some huge loss in those communities of how to be around the time of having a birth. And then, of course, there are cultural practices around a baby coming, right? We all have different kinds of things, amongst my peers, it's that there's a baby shower and then the baby comes and people around you like bring you food and maybe some presents for the baby and offer help and support, and different people have different cultural practices around birth, but there's a lot, right? And in Indigenous communities there are spiritual practices around the birth, and those things are very tied to land and place and community. And so when people have to leave their home community, they're leaving what ties them to those cultural practices and the people who can help them participate in it. And then you go into a health system that wherever you are is biased against you, right? We know, for example, that Indigenous babies are taken away from their parents at higher rates, that people are sort of looking for, oh, there's a risk to this baby, I have to report it to the ministry, unconsciously looking for those kinds of things more amongst Indigenous people than non-Indigenous people. They're overlooking things in a non-Indigenous person that makes them think a baby is at risk if it's an Indigenous baby. And so people know that if they're going into a healthcare system, they're at risk. The baby might get taken away from them. They might be treated badly. Their concerns might be discounted. They might be assumed, if they are experiencing pain or distress, that they're addicted to alcohol or drugs, and that they're seeking help for their pain or distress because they're trying to seek substances. And so there are all these barriers that people sort of have to steel themselves against if they are Indigenous navigating our healthcare system. And that does mean that they get poor quality healthcare from the people who should be there to take care of them, who are entrusted with that role of taking care of them. So I think it adds up in lots of ways. And I'm speaking as a non-Indigenous healthcare provider, somebody who has lived experience with this. Of course, it would have lots more to say on the topic, I'm sure, but those are some things that I've been learning and reflecting on in the past years.
Yeah, thank you for sharing that. It seems like there's so much at play between the fracturing of their secure family dynamics by our system with colonialism, and then also all of the intergenerational trauma that comes with that. And then having to travel to a new place that's unfamiliar to receive healthcare that isn't culturally sensitive or supportive, and you're away from your home and your land and your language and your culture. And yeah, it just seems like it would be a lot to take. So I know that you were mentioning before the podcast that there's an increased recognition recently, though, with regards to returning birth to Indigenous communities. For someone who hasn't heard anything about that, I was wondering if you could just give us a bit of an introduction as to what that means and why that's important.
Yeah, for sure. So, again, just acknowledging my position that I speak from. I don't have direct, well, I don't have direct experience, I have indirect experience. So there is a real movement within Indigenous communities to address these disparities and bolster culture and connection to land and community. And birth is such a wonderful thing in a family or community, right? Like, who's not excited for a new baby, right? Like, pregnant people, have people like coming up and touching their bellies and stuff in ways that like people normally wouldn't touch your body, because it is like, it's a community thing, like a community is excited for a new baby. And that's kind of a beautiful thing that happens around people having new people. So it's nice when that can happen in communities. And so I'm aware of some cases where the I assume supported through the First Nation Health Authority, providers have traveled to communities to wait the birth rather than the patient traveling from their community to await their birth with the provider. So reversing that travel dynamic and and having a provider in a community where there's not normally birth there and available. This is something working in the Yukon that we don't have yet, but there are areas of Canada where there have been for a long time now some programs to train Indigenous midwives. So it's a separate specific stream of midwifery training for Indigenous people to provide Indigenous-centered midwifery care. So they're able to, yes, have all of the same tools and skills and sort of like Western medical knowledge and experience of a midwife, as well as the cultural wisdom and centering of an Indigenous culture. And so those people are doing amazing work to bring birth back to communities where they themselves may be living already, right? And do it in, learn about and revive cultural practices around birth that have been lost through colonialism. So there's just some really inspiring stories happening of people who, chose to advocate for themselves and for the resources to be able to have their babies back home because they felt that all of these things were really important for them. And I think it's neat to think about reversing some of the who travels and what do we consider valuable? Do we consider it valuable that you're in a hospital having your baby, or do we consider it valuable that you're having your spiritual and cultural needs met around the time of your birth, and that your community is also,
Yeah, for sure. I guess it just comes down to considering risks in multiple contexts, not just the risks of not being in a hospital, but the risks of being away from your culture and all of that.
Being in a hospital, that's
Yeah.
there are risks to being in a hospital.
Are there any initiatives or resources with regards to that you know of or would like to mention?
So I know that the first, as I'm involved to peripherally to really speak to it, but I know that the First Nation Health Authority, has a department that is working on this and supporting it. And they have a wonderful rural physician who herself comes from a rural area, who is their lead. And so it is something that has dedicated work happening right now. I can't really speak to how that's organized and how that's happening, but in BC we have these dedicated health authorities that look at sort of set geographical areas and organized care, and we have northern and interior and Fraser and coastal and island health, but there's also a province-wide First Nation Health Authority, and they're the ones that manage all of those small nursing stations that are providing lots of care. A lot of it is in the northern part of the province where it's a bit more remote, but it's not exclusively there, as well as several programs that are targeted specifically at Indigenous people's health. So it's definitely a organization that's doing some pretty amazing work and has lots of Indigenous people within its administrative ranks, and they're definitely at the forefront of that in BC.
Okay, great. Thank you. So moving forward, not just with regards to a specific factor, but just in general, if we know that the outcomes aren't really worse for healthcare that's delivered rurally. Why aren't we there yet? And yeah, if rural healthcare, when the resources are there, isn't less safe or effective, why haven't we seen a greater push towards that? And I guess in simpler terms, what are the barriers standing in the way of sustainable rural maternity care?
Yeah. Well, the people who make health policy decisions are in urban areas. Right? That's where
Mm,
governments are. They're in Victoria, they're in Whitehorse, they're in Edmonton, they're in even in the territories where people think of Whitehorse as rural. Well, there's still 35,000 people in the city, and their lifestyles are pretty different than a community of 2,000 people, right? And
hmm
so I think that's a huge problem, is that the people who make decisions aren't living that life, right? And there are a lot more people in urban areas, so there are more elected officials in urban areas. And so there's just not that understanding within the system, I don't think. It's also, when you're just like living your life, it's hard to find the energy to advocate for those things, right?
mm,
If you're if you are a pregnant person and you're realizing some of these things, well, you're just trying to get through your pregnancy, and every time you have to have an ultrasound or something, you have to get in the car and drive 6 hours and pay for the gas and miss work and figure out childcare. Do you really have time to put in the work to advocate and highlight these things? Probably not. So I
hmm
think that's part of it. Is it's just a prioritization and representation issue. um, yeah, and it's, there are many, many things that people allocating health resources have to consider. Another thing that is universal to the healthcare system right now is that we've reached a tipping point with the pandemic. It is not only due to the pandemic, but it has been the sort of tipping point in health human resources. And all of a sudden, nationwide, there's staffing shortages, and
hmm
that is not, unfortunately, a great context for trying to start new programs up again in rural areas, right?
Yeah, yeah.
When you can't even staff your existing consolidated area. So I think that is a huge barrier that probably needs to be sorted out before some of these other things can, unfortunately, that's made things worse, when it would be nice if we could be moving towards better.
Yeah, of course. Is there anything we can be doing as individuals to help this shift back, either to help the shift or just to work better with what we've got right now?
Yeah, that's a great question. Well, I think that, for anybody, like I know you're doing medical training, anybody working in the system, just hearing people's stories and understanding what people's lives are like is huge, right? And taking that into consideration, wherever you are, if you're caring for somebody, whatever their story is, it makes a big difference. But particularly when you're dealing with somebody who doesn't share your background, it's a really simple thing, but actually just like listening and thinking about what it means when you say, oh, you should get another ultrasound in a couple of weeks. Like, well, what does that mean for somebody? To make a recommendation to them, and inquiring and asking and thinking about how they'll do that. That's something that anybody in the healthcare system could do with any patient, and would help people immensely be able to actually get healthcare. Um,
Mhm.
I think that awareness is huge. If it's something people really feel passionate about, you can think about that when you do things like vote. If you're in someone who's interested in policy, you can make sure you can think about what voices are at the table when you're making decisions, and think about whether there's representation of people from different cultural and population and geographical backgrounds at the table when decisions are being made. And if there's not, you can make steps to address that. And I think in the system, we can keep thinking creatively, as we've been forced to do, about like how can we do things different? Can we take what we have and move it around virtually, or actually can we send some midwives away to a different community for a while? Can we spare that instead of always thinking in one centrist way that everybody has to come into the center? Can we think about how to redistribute resources that we do have differently, rather than keeping them all in one place?
Yeah, I think it has a lot to do with thinking outside of the box that we're in here. Being in Vancouver, it's so easy to get stuck in thinking about the way things are here. And I can see how that would impact policy too, because if the people making the decisions there with regards to policy are here, then it's just not readily available in their minds what it's like to live totally differently and what the implications of their decisions here might be.
That's right. Yeah.
But that was a really good point with regards to making sure, like as a healthcare provider, when making recommendations for appointments or seeing a specialist or anything like that, to always consider what the individual's circumstances are and what the implications of your recommendation might be. So we're almost at the end of the episode now. It's been a really great hour, but I was just wondering, before we sign off, do you have any closing messages or key takeaways you'd like to share if the people listening to this could remember one or a few little things that you think are extra important?
Yeah, I think just being attuned to what people's lives are like and what their stories are like, right? And thinking about all those ways that something impacts people. And you really only get that through experience and listening. So, go experience different things. Maybe that looks like doing a rural rotation somewhere. Maybe that just looks like working with a different population within your urban area than what you normally culturally interact with, to just have that experience of, oh wow, I'm kind of other here, and there's a lot of things that I'm actually unfamiliar with, and being open to really assessing what that looks like. That's huge, right? And until we're sort of confronted with, oh, this way that I see things isn't the only way, it's hard to have that openness to people. And that's something, the world would be a better place if we could all constantly improve in that, I think, and in openness and understanding. So finding ways to cultivate that, I think, will make everybody better in the healthcare system.
Yeah, there's a lot to say about just increasing our own awareness and doing our own learning or unlearning and starting from the individual. So yeah, I really appreciate you sharing that. Okay, this has been a really valuable conversation for me. I really appreciate you taking the time. Yeah, I really appreciate it, Sheila.
Yeah, my pleasure. It was nice talking to you, and thanks for your interest in this topic.
Yeah, of course. Have a great night.
Thanks, you too.
Thanks for tuning into Just Medicine today. I really hope you enjoyed the episode, and be sure to keep your eyes and ears peeled as we've got a lot of other exciting episodes on the way. Until next time.